All right, welcome to EMS Updates. We are going to talk about bradycardia. This has been something that we anticipated would have some questions when we rolled out the update to the Central Arizona Guidelines earlier this year. We wanted to go over today why we made the changes and also hopefully help explain some of the questions that have come up as part of this. One of the things that we changed with this was really talking about when to use transcutaneous pacing for bradycardia. We updated the language regarding pharmacologic management as well as removing benzos as an option. We'll go into the reasons that we removed benzos and also added fentanyl as the option for treatment if you are using transcutaneous pacing. So why so many changes? This is probably the biggest question we get anytime we make substantial changes to the guidelines. What is the reason for this change? And the most important reason we made this change is that we've had instances across the state where there has been missed cardiac arrest in the setting of pre-hospital transcutaneous pacing. And that's actually relatively common. There's been several recent national articles that have also addressed this trend, and these were published during 2024. So these changes were made not only in Mesa, but also across the central region as well as in southern Arizona. So really over half the state has made the change with the updated to the guidelines for 2025. Transcutaneous pacing is typically performed in patients who are quite ill, and these patients have a high risk to progression to cardiac arrest. Some of our previously used options for pharmacologic management of transcutaneous pacing also increased your risk for hypotension, which is problematic, especially in patients who are otherwise quite ill. When we look at the bradycardia treatment guideline, the key change that we made was with the unstable patient population. The key that I want to point out with this is that when you look at bradycardia, when you're determining whether or not to go to the cardiac arrest guideline, the first step you're going to look at it is the patient unstable. So if you have someone who has signs of shock, impending cardiac arrest, and hemodynamic instability, if that is their first step, your next step is to determine are they unconscious or unresponsive. If this patient is unconscious or unresponsive and hemodynamically unstable, you're going to go directly to your cardiac arrest guideline. If you have someone who is unstable, so they have signs of shock, they could be hypotensive with a systolic pressure in the 80s, but they're awake and talking to you, this patient would be the ideal patient to initiate transcutaneous pacing and push dose epinephrine. We want to make sure that those two interventions are being done simultaneously. If someone is stable, so they have a normal blood pressure but has a heart rate that's in the 30s, this is someone you could use push dose epinephrine or atropine. For pharmacologic management for transcutaneous pacing, one of the big changes was to remove benzodiazepines. The reason for the removal of the benzos was the risk for hypotension, respiratory compromise, and neurologic depression. We know that anytime we give benzos, all three of those are potential side effects of the medications. As a result, we really looked at what we do in the hospital setting. In the hospital, we usually will use fentanyl, and the reason we use fentanyl is that it does not have the same risk for respiratory and neurologic depression, and it also has a very low risk for hypotension. If someone is unstable and going to get transcutaneous pacing, and you give them a dose of Versed or Ativan, that patient has a very high chance of becoming hypotensive and going into cardiac arrest. By using fentanyl, we are going to lower and decrease the risk for that. The dose for fentanyl is going to be 1 mic per kilogram, and it can be administered intranasal, IV, or IO with a max initial dose of 100 micrograms. You can repeat this one time for a total of 200 micrograms. The thing to keep in mind is these patients are often elderly, so if you have an elderly patient with bradycardia that you're going to consider doing transcutaneous pacing, and they're greater than 60, you want to reduce your dose of fentanyl in half. So if they are 50 kilos and you would normally have given 50 microgram, this is a patient you would want to consider starting with 25 micrograms. Remember, you can always give more of a medication, but a higher dose medication, once it's in that patient's system, is hard to reverse. So why are we starting chest compressions if the patient is unconscious? This has been the big question that I've gotten from a number of providers. And our number one goal to keep in mind is we want to make sure we don't miss cardiac arrest. There's many other medical conditions that are going to deteriorate into a bradycardic rhythm just before the patient goes into cardiac arrest. And if you think about all those patients that you have that are critically ill, and when someone says they are starting to brady down, that conversation of bradying down is your indication that that patient is going to go into cardiac arrest. We know that patients who have tachycardia initially are at really high risk once they become bradycardic to go into full cardiac arrest. Once someone loses consciousness in the setting of bradycardia, your threshold to start CPR should be very low. I use an example from my own father who was in a complete heart block I was with him in the emergency department as well as in the ICU. Despite being profoundly hypotensive to the point of causing multi-organ failure and shock, he was awake and conscious throughout that time. And it really was a sign to me to demonstrate how much the body can compensate. So you are still able to perfuse the brain and yet in a shock state. So this is a patient population, if they're in shock but are hypotensive, you want to make sure you're using a push dose epinephrine as well as a transcutaneous pacing. This article was published last year, and I thought it was a really good way of thinking about why is pacing not working in the pre-hospital setting. So the title of this article was False Electric Capture and Pre-Hospital Transcutaneous Pacing by Paramedics, a Case Series. The table is a little bit busy, but if you look down at the discharge diagnoses, you can see that there are lots of reasons that pacing is not going to work. When you have an example of acute respiratory failure with hypoxemia, cardiac arrest and GI bleed, anoxic brain injury, large left intracranial hemorrhage, a massive pulmonary embolism, metabolic encephalopathy due to UTI and bacteremia. All of these are things that are not going to respond to transcutaneous pacing. Pacing is going to only fix an electrical issue. If you think of something like a pulmonary embolism or hypothermia, these are not necessarily electrical issues. You need to treat the underlying cause. If you don't treat the underlying cause, unfortunately, that patient is going to progress from bradycardia into cardiac arrest. In reviewing EMS charts, often when we see the failure of transcutaneous pacing, it will be a patient who has a respiratory complaint initially. They're often hypoxemic, tachycardic when EMS arrives on scene, and they start to brady down. As you started to see that development of bradycardia, that is the patient that you really need to be concerned is going to go into cardiac arrest. And that patient does not have an electrical issue that's causing the bradycardia. When you try to initiate pacing in that patient, unfortunately, you're only addressing what you're going to see in a monitor, but you're not fixing the underlying issue. We have seen several cases of missed cardiac arrest in that patient population. This next article was also published in 2024, and it was titled Pre-Hospital Transcutaneous Cardiac Pacing in the United States, Treatment Epidemiology, Predictors of Treatment Failure, and Associated Outcomes. One of the things that I wanted to point out is to demonstrate some of the key statements from this article. The first is the statement that a non-bradycardic pre-pacing heart rhythm was associated with increased odds of failure, cardiac arrest, and mortality. What that means is that if the patient's heart rate when you get on scene is greater than 50, so they're not bradycardic initially, and they start to become bradycardic, they have a much higher rate of pacing failure, cardiac arrest, and death. Patients with initially a normal or elevated heart rate that then become bradycardic prior to initiation of pacing are also less likely to have effective transcutaneous pacing. The authors found that pre-pacing hypoxemia and initial impression of respiratory distress or arrest was also associated with pacing failure and mortality, keeping in mind that patient population with difficulty breathing, whether it be asthma, COPD, pulmonary embolism, if it's a respiratory issue that's causing hypoxemia, and now they're starting to develop bradycardia. The bradycardia is developing because they're not oxygenating their heart and brain, and pacing that individual is not going to be successful. Bradycardia is part of the final common pathway to death for a number of pathologies. I think that statement really is quite a summary of why it's not going to work when we pace these individuals. Patients who are in circulatory shock, so if someone has a hemorrhagic shock, that bradycardic rhythm is the rhythm you're going to see before they go into cardiac arrest. Whether this is someone who has a gunshot wound with a traumatic injury, I see this not infrequently in the trauma bay. You'll have a patient who comes in awake and alert, they're tachycardic, they're in shock, they often don't have a good blood pressure, and then all of a sudden they start to lose consciousness, they start to have a bradycardia, and that patient almost universally will proceed to cardiac arrest. In that patient population, pacing is not going to fix them. They need blood and they need resuscitation. So keeping in mind, what is the precipitating event that is causing the bradycardia? And the final statement from this article was really talking about that training and education should focus on treatment of reversible causes of bradycardia prior to initiation of pacing. So to pace or not to pace, transcutaneous pacing in the pre-hospital setting is a low-frequency, high-risk intervention. Maintaining and tracking capture in the back of a moving ambulance is also very difficult. You want to have a very low threshold for initiating CPR. If the patient is becoming increasingly bradycardic, especially in the setting of respiratory distress or failure, think of bradycardia as impending cardiac arrest. Again, quote, the patient's bradying down. Pacing will only work on electrical issues, and any other cause of bradycardia will not be fixed by pacing. So what are some pitfalls? So this was another article. This is from 2021, and I thought it was interesting how they focused on using, if you are going to do pacing, that you need to confirm capture with point of care ultrasound. So that's what POCUS stands for. We don't have point of care ultrasound. So in the pre-hospital setting, it's really hard to confirm pacing with mechanical capture, especially in the back of a moving ambulance. So what are some risks associated? The key thing is to make sure we don't miss pseudo capture. Chest twitching is not uncommon, and it does not mean anything. It does not mean you have capture. You may see on the monitor what looks like great capture, but we don't know necessarily that that patient has good mechanical capture. In the back of a moving ambulance, going down the road or freeway, especially at a high rate of speed, going code 3, confirming that you have continued mechanical capture can be quite difficult. If a patient goes into cardiac arrest and we've missed that, that patient has no chance of survival if CPR is not being performed. And remember that bradycardia can be caused by MI and lots of other issues. So if you have someone who overdoses, they become hypoxemic, and then they start bradying down and go into cardiac arrest, that patient is not going to be fixed by pacing. You need to fix whatever was the underlying cause, which is going to be addressing their hypoxemia. So what do these rhythm strips have in common? So these rhythm strips were all taken from Zoll monitors on patients who were getting transcutaneous pacing. And you can see here the patient's rhythm prior to the initiation of pacing. All these patients were in cardiac arrest, and unfortunately it was not recognized. One of the key fixtures when I look at this is that the patients had no spontaneous respirations, they had no pulse oximetry or very low pulse oximetry, and no blood pressure. So if you have someone, again, hemodynamically unstable, you've been able to place an eye gel, you're bagging them, they're not responsive, you don't have a good blood pressure, you don't have a good pulse ox, your end-tidal CO2 is low, all of those are signs of a patient who's in cardiac arrest. As you can see in the two pictures on the side, it does look like they actually have capture. Unfortunately, they had electrical capture and not mechanical capture. Both of these patients arrived at the hospital or were determined after several minutes of being paced to actually be in cardiac arrest. So they went that period of time without any compressions or resuscitation. So what about atropine and bradycardia? One of the other questions has been, when should we use atropine, if at all? So atropine is certainly still an option, and it must be used for patients who are really stable. So in the past, atropine was used for unstable patients, but what we know is that epinephrine is much more effective. Epinephrine is going to work in a much larger percent of patients. I like the circle at the bottom where you see the small percent, about 25% of patients who will actually respond to atropine, and then the remainder of the patient population who will respond to epinephrine. If I had a choice in the hospital and I had to decide, am I going to use atropine or am I going to use epinephrine, my first line choice based on this is going to be go straight to the drug that's more likely to work. If you are going to use atropine, the dose was increased a few years ago. It was previously 0.5 milligram for the dose for treatment of bradycardia. The dose is now 1 milligram IV or IO for atropine and a maximum dose of 3 milligrams. So why was the atropine dose increased? So this was increased in 2020. And the reason for this is at low doses, atropine can actually decrease a patient's heart rate. And so at higher doses, the atropine will increase the heart rate. So especially in a patient who has bradycardia, we certainly wouldn't want to potentially lower their heart rate even further. And so this was the reason for the increase in the dose from 0.5 milligrams to 1 milligram for the atropine back in 2020. So this gets into why we want to really get into the treatment of choice, which is going to be your epinephrine. So progressive bradycardia is often a harbinger of death. And this is really an easy way of saying this patient, if you have someone who is developing bradycardia in front of you, is really high risk of progressing to cardiac arrest. If you have someone who has known bradycardia or is stable with bradycardia, simply they can be treated as such. Many patients will have bradycardia and they start to become more symptomatic, and that's at the point that you want to intervene. However, if you have a patient who is unstable, you want to make sure you're going down the right pathway for this patient. So epinephrine and bradycardia, the advantages of epinephrine is, unlike atropine, epi stimulates the entire myocardium. It provides a broader spectrum, so it's going to treat all causes of bradycardia. And it's safe for use for peripheral infusion, so you do not need to use a central line. So who remembers when we first started CCR almost 20 years ago? At the time, everyone thought we were crazy, focusing on CPR rather than airway management. However, once Arizona started initiating CCR, what we found was that we had an increased survival from out of hospital cardiac arrest. And this was a really substantial increase, not by a small percentage. As a result, this has subsequently become the standard of care and has been adopted by AHA and across the entire country and world. This is something truly that I think we need to look at when we make substantial changes. While this may seem, quote, crazy that we're actually starting chest compressions in a patient that may have a pulse, the reality is if someone is unconscious, hemodynamically stable, and bradycardic, if we miss cardiac arrest and we start pacing them, that patient has no chance of survival. With many of these patients, when we've gone back and looked at the charts, we actually unfortunately saw the evidence that this patient was truly in cardiac arrest. Recognize that step one is to ask, does this patient have hemodynamic instability? If they're hemodynamically unstable, that patient, then your next question is, what is their consciousness? If they're unconscious, hemodynamically unstable with bradycardia, that patient needs to get chest compressions and epinephrine per the cardiac arrest guideline. If they're hemodynamically unstable but they're conscious, that individual you can go to pacing as well as your push dose epi. And for a stable patient who you want to intervene on, these individuals can get either push dose epi or atropine. Remember that pacing is only going to fix your electrical issue or conduction issues. There's many causes of bradycardia, and those things need to be treated differently. If bradycardia is your final rhythm before cardiac arrest, we want to address and treat whatever the preceding event was. So if it's trauma, hypoxemia, respiratory distress, overdose, we want to treat those underlying issues if we start to see progressive bradycardia. That is it. If you have any other questions, please feel free to reach out to EMS and we'll definitely get back with some more Q&A answers. Thank you.